We now move on to the keynote, and which is the last session of the day as well. I'll wait to introduce our keynote speakers when we've got them online. They're going to be joining us all the way from the UK live. So I'll give it a couple of minutes till we're able to get them. Are they on? Hello.
We're here.
That's excellent. Our logistics team has worked very hard to make this happen. So hi, Dr. Gabby, hi, Dr. May. Very nice to see you. I hope you can see everyone. So for our keynote today, we have Dr. John Gabby and Dr. Andree Lee May, professors emeriti at the Southampton University, joining us online for a session on Mindlines and mental health. Dr. Gabby and May's ethnographic work has led them to posit the notion of clinical mind lines and to highlight the importance of communities of practice when implementing improvements in healthcare. Mind lines are internalized, collectively reinforced, and tacit guidelines that healthcare professionals use to make decisions in their daily practice. So I'll hand over to you, Dr. Gabby and May, to please start your presentation. Thank you.
Thank you.
Can you see our slide on the screen?
Yes, we can see your slide.
Lovely. Well, we're very honoured that you've asked us to speak at your conference and that you've taken an interest in Mindlines. We thought it would be useful to slightly amend the title, however, of our talk, because it's not just about the theory of Mindlines that we want to talk. It's also about how one can use Mindlines to actually make a difference to the care that is provided. Andree and I have spent many decades trying to get evidence into practice and trying to understand why that happens. And that's what we'll be talking about today, but also later on in the talk, we're going to talk about how we've used this model, the Mindlines model, which we'll explain, to change services and to improve services.
So to begin with, you can see from this slide that we've had a lot of research projects for the last, nearly 25 years, which have focused around implementation, knowledge mobilization, the design of services, and what skills people need to implement evidence in practice and also to make improvements. So what we're saying today is really based on 25 years worth of research in different areas. And behind all of that are a number of theories. We're not going to go through any of those, but the point of showing you is that we have a vast array of theories backing our work and driving us forward. It's a very eclectic mix. Our disciplines in medicine, in nursing, in social science, in the implementation of research require that kind of mix to really make things understandable. When we do research, we obviously have preferences. We prefer to do ethnographic, case study, and action-focused research, and also to encourage participation and inclusiveness, to try to ensure that the research, and when we put it into practice, it's developmental, so it builds capability and capacity. And probably most of all, listening to some of what you've been talking about this morning, one of the important things about our methods, because they're action focused, is that we're building relationships, building trust. And recently, we've been doing that more and more as practitioners of implementation of research, rather than simply as researchers.
There has long been, and unfortunately still continues to be, a very naive view that implementing is a very rational and linear process. The scientists create the knowledge, the systematic reviewers will validate it, the comms people will disseminate the knowledge, and because people receive that knowledge, they'll implement it and they'll practice it. Well, of course, life isn't at all like that. When we first got together to work in this field, Andree and I were asked to help two groups of multi-sectoral groups to implement better care for the elderly in their area. And the idea of our funders was that we would provide them with a librarian, with the knowledge they needed to take forward the answers to the questions that they wanted to solve, and that they would simply put this into practice. And as we watched them with researchers putting that knowledge to some use, what we found was very different. This was what they were doing with the knowledge that was introduced to their discussions. A very messy, complicated, haphazard almost set of activities that change the knowledge that is put in from research by the librarian into something that suits their context in a very different way. And this led us to think, well, what on earth is going on here? We're not the only ones who thought this. Over the years, there have been many, many attempts to understand and use methods to try to get evidence into practice. These are many of them. We particularly are interested in the models and frameworks that people have used to try to understand and mobilize the understanding to try to change practice based on research evidence. And as a matter of fact, Andree and I were working in a job as implementation leads in an organization in the UK where we were training implementation fellows. And if you look on the, you'll have these slides later, if you look on the website, you'll find lectures on all of these ones in the right-hand column there, the various models that we think are important, most of them given by the people who develop the models. So feel free to look at that. That also includes a lecture from us on Mindlines. And here's the website if you want to go to that.
Now, based on all of this work, we tried to formulate a model that we hope helps people think about how best to implement evidence in practice. And you can see from this that it's got 4 circles. And I'm just briefly going to go through each of them in a minute. So it starts off at the top with evidence, ensuring that evidence that is used is robust, is relevant and is ready for use. Most importantly, thinking about the context into which the evidence is going to be implemented. I've already heard you talk a lot about context and how relevant context is and how difficult and inappropriate it sometimes is to take research from one context and naively implement it into another. So when you're thinking about the robustness of research, you're usually thinking about critiquing it for methods, for design. But in this instance, I think when we're transferring research, we need to really think about, can we transfer from one context to another? What does the context that we're working in require of the research? So we would advise people to think about the inner context, the resources that are available for changing things, the skills, the local politics, and the outer context, the demands placed on the organization. They might be political demands, they might be social, economic demands. All wrapped up together, they form an important aspect for consideration, the context. Now, you've talked a lot already this morning about people, and people are really at the heart of implementation. They are important because they are the key players in any change, and any implementation strategy needs to be inclusive, working out who should be included, why they should be included, what they think, what knowledge they use, why they use that knowledge, how they use it, and what knowledge they also need. So how does the evidence that you might be presenting to them fit with what they already know? People use lots and lots and lots of sources of evidence. When we talk about evidence, we don't just mean research evidence. So we've got on this slide many, many different types. Your own experience, experiences of others, of opinion leaders, what networks are saying to you, your own reflections, what professional meetings are telling you, like the one that you're at for the next few days, your education, where it stops, have you been updated, and what systematic reviews, local protocols tell you, and importantly, what stories and case studies say as well. So you're getting together a whole bunch of evidence that will help you think about how to change and how to improve care.
Despite our understanding of all of this, Andree and I were very concerned that we still didn't really, nobody really understands why it is that professionals appear not to put into practice some pretty obvious research results that would be useful. And we had the surprisingly unusual idea of saying, well, let's not just tell them how they should do this. Let's see what good practitioners actually do, which is why we turn to an ethnographic method of, which is what anthropologists do, living with, as it were, the tribe and trying to understand how they think, how they work. And we, in 2001, started looking at primary care practitioners to see how they actually use knowledge in day-to-day practice, and that resulted in the book about clinical mindlines. Just to briefly tell you what the design of the study was, we chose the best practice in the area by many measures, an 8-partner general practice with some nurses, a leading edge in a small rural UK town. We did an ethnography initially for 2 years, but actually in the end, we stayed there for about 8 years, just attending meetings, going to the coffee room, chatting with people and trying to understand why they were thinking and practicing the way they were through observation, both participant and non-participant, by interviewing, by multiple interviews, group discussions, informal discussions, and so on. We, as the results were emerging, decided we should check if this was also happening in a very different kind of practice in a large urban town, city in the north of England, which we also did. We conducted thematic analysis, as you'd expect. And then as the results were emerging and we realized what was going on, we looked at medical students learning about psychiatry, as it happens, and also followed a medical team in an American hospital to see how they were using and acquiring and putting into practice knowledge. The main finding that we had was this concept of mindlines, which, as your chair has already explained, are internalized, collectively reinforced, partly tacit guidelines in the head. That's where the term mindlines come from. These are the guidelines that you accumulate throughout your professional life that tell you what to do in any particular situation, and often a very complex situation for which the written guidelines and the protocols do not apply, because things are never quite as simple as guidelines think, because of the context that Andree was talking about and because of the people you're working with and what they think might or might not work. So the knowledge in theory that we get from research is not the same as the knowledge in practice and in context, as Andree and I like to call it, as almost one word, knowledge in practice in context, which is very different from theoretical knowledge. And a mindline is your own mental embodiment of that knowledge in practice in context. It's much more flexible and malleable and practical and contextual than any guideline can be. It's also much broader than something that the educationists among you may know about, like heuristics, illness scripts, rules of thumb. These are the pattern recognition that we know from research clinicians use to immediately spot a pattern of symptoms and immediately know what to do about it without really having to think about it. But in the context of practice, and particularly mental health practice, but general practice as well, and indeed even in surgery and many other situations we've now found, it's much more complex than that, much more messy. So what's in a mind line? Well, if you start at the left-hand side, 9 o'clock as it were, in this mush of spaghetti that's in our brains here, you've got the guidelines, of course, which you know about, and you've got the science and the rules of thumb and the heuristics and the illness scripts and the technical skills that you acquired during your professional training. You've also got the soft skills and the practical skills, but you have also developed tacit and experiential knowledge. You've also embedded your trainers and your teachers' norms and ideas into your thinking, and there will be local norms and routines which may differ from place to place and usually do. You've had role models that you admire and that you wish to emulate and whose opinions you tend to favor, and you have an institutional culture that says this is the way we do things here, which might be different from where you used to work, and that is all built into your immediate response to a particular complex clinical problem in front of you. And you've got your peer values as well as to what is or is not acceptable. At the bottom here, when you get these slides as a PDF, you'll be able to click on uh, the links at the bottom here to get to the papers and so on about this. The 2016 one is a nice 2-page summary, which you might find useful. Now, the point about this is that when we talked and watched the clinicians, we didn't necessarily find research evidence being quoted as such. And it's also very important to recognize that it's not that guidelines are different from Mindlines. They're different, but they're not opposed to Mindlines because Mindlines include guidelines. And in fact, some recent work on Mindlines has shown that many of the guidelines that are produced by organizations like NICE, the National Institute for Clinical Care and Excellence, which you may know about in the UK, and other national organizations producing guidelines, they also smuggle in the panel members' Mindlines because there often isn't the research evidence there. So Mindlines and guidelines are intimately connected. The sources of evidence, I'll leave you to look at the slide, but basically many, many sources of evidence. Starting at the bottom there at 5 o'clock, you've got the textbooks and the education sessions and the teaching training. But you've also got the local infrastructure. You've also got your own experience, your patients' views, your colleagues' views, the clinical pharmacological representatives and others, local guidance, central guidance, and this sort of vague idea of what it is that opinion leaders and they say. A lot of they say was found in the meetings that we went to. The appropriate way to treat this, they say, is X, Y, Z. So many, many sources are melded into this guideline in the mind, this Mindline. Again, very little mention directly of researchers, but of course what the researchers say is embedded in much of what you see before you in that slide. We liken this to a compost heap, and this is our compost heap. Andree and I, by the way, are a couple, so we share a house, and we have a compost heap in our garden into which we put all sorts of different items. Imagine that as an analogy with all the different sources of evidence that we showed you earlier, going into this compost heap. And somehow, by psychosocial methods that we'll talk about in a moment, this is transformed into compost. It's transformed into something that we can use very effectively, our knowledge and practice in context. And it's that magical transformation of research knowledge and other types of knowledge that guides good practice. Now, guidelines are not just in one person's head. We all have our Mindlines, and when we watch the practitioners talking, interacting, discussing their patients over coffee, arguing with the drug representatives who came around, listening to consultants, going to lectures, they were sharing their ideas and their Mindlines to develop what was the collective Mindline. So in a particular practice, this is the way that we deal with a homeless person with a psychiatric problem. In another practice, it may be very different. The way that these Mindlines are shared between people is at conferences such as the one you're at, but also informally in over dinner and in the bar, sharing anecdotes in the coffee room, over the water cooler, formal case reviews as well. But whichever method it is, so much of it is through telling each other stories about our patients, about our practice, about our experiences, about what we've heard other people say works or doesn't work, and why that might be. And that shapes that blob of spaghetti in our brain that helps us to deal very effectively and efficiently with work. Now, because many different people are sharing their Mindlines and talking to each other, it becomes like a pinball machine. We like to call this the implementation game, because each person puts the ball into the implementation machine in a slightly different way. And it's not a ball, it's not a steel ball, it's something, I don't know whether you have in India, a substance called potty putty, which is a toy for children. It's basically a lump of silicon that you can change its shape into anything you like, a bit like soft plasticine. So what goes into the machine is this malleable substance that is bounced around every different actor's Mindlines the implementation game, I'd explained about potty putty and how at each item inside the implementation machine, the knowledge gets slightly changed because each person has their own mind line and each person has their own view of what's going on. And I was using an example of some research I did years ago, about in the 1980s, where we were trying to understand why people were not using the appropriate research-based treatment for heart failure. And as we looked at what was going on, we recognized that there are many, many different actors, many different organizations, people, resources, institutions, all of whom have a different view of what we mean by heart failure, what the implications of it are, and what's best to do about it. So that the knowledge from the research is transformed by every person, every organization that deals with that. So the finance person has a different view from the patient, who has a different view from the carer, from the doctor, the nurse, and so on. Each actor transforms that research knowledge. Now think about that when you're a health professional dealing with somebody who walks into your organization needing help. You as a health professional have your formal guidance on what it is to do with this particular problem, maybe schizophrenia. You have the collective view of your institution, which may differ from one up the road, and you have your own mind line. But the client who's walked in also has their views portrayed, the sort of national view or the local view or their own community, their own friends, their own family, their views of what matters here, what works and what doesn't. You want to try a new treatment, and I'm sorry to use the word treatment because in the last session I think there was some question about whether that's the right way to think about things. But let's imagine that we are thinking about a particular way of handling the problem, and we'll talk later about one that doesn't involve medical treatment. But the client has heard about this and they're not sure. They have their own view on what they've read about it. They've spoken to their friends. They've met people who've experienced it. Somewhere in the middle of that is some kind of negotiating area where there is some overlap between the professional's mind line and the clients and their family's mind lines. And we call that the negotiated single instance of what you can do for this person in this context at this moment. A good example of this is a study I was involved in back in the early 2000s, looking at people's views of depression. And there were many different views that it might be biological or biochemical, or it might be a psychosocial thing. And some people thought that antidepressants work best, but other people thought that counseling works best, that it's more social, that perhaps it's even in some cases people thought of it as a form of moral weakness, goodness me, rather than a biochemical imbalance or something else. Now, if you have a professional who has one of those views and a client and their family who have another, and it can be either way around, by the way, the area they have for developing an understanding and a trust in each other's views that they can agree a way forward for that person in that context at that time is quite limited because of the overlap of their views or the lack of it. So let me just summarize where we've got to so far, particularly because there was a break. We've talked about the target people in that four-circle model having very different things that they do with knowledge, which we discovered in our first study together, Andree and I, about how they change it, how much more complicated it is, and that this might be due to mind lines, which are not just individual, but collective, and that means that everybody who's involved in giving or in the care context will have a different view, which somehow you need to overlap and find an area for negotiating what is appropriate in that context. Now, the question is, what do we do with this theoretical knowledge that we've come up with in our research in a way that works to try to achieve successful implementation of knowledge in practice, in context?
So this is really where the work we did on Mindlines merges with the continuing work we've been doing on implementation. So we talked about the target people. We just to emphasize that the target people will have their own Mindlines, which are supported by their colleagues, people that they interact with, their families, and the organizations. But to make something happen in practice, you have to make a change. So you have to select a change method that will suit the people that you're working with. Now, I've said already that we prefer relational methods, so we've chosen to use communities of practice in most of our work. But we've also identified in that work, and this is pretty obvious, that you need to have really good management and facilitation skills if you're going to enable a change to happen. And a change can be very small or actually quite large. It could be about an individual and their care, or it could be about a whole way that an organisation or an area goes about delivering care.
So this method that we're going to talk about now is rooted in the Mindlines model that we have been explaining to you.
So we think first of all about implementation, and really it's all about people. It's about interacting and communicating effectively, being respectful, being inclusive, cooperative, collaborative, robust about dialogues, but having supportive dialogues so you can challenge and you feel comfortable challenging. It's about working together again towards action that solves real problems, as opposed to just thinking about things theoretically, or not really trying to solve a problem that is of particular relevance to those people involved. So proficiency is important in relation to three sets of skills: interpersonal and organizational skills, technical skills, knowing about the evidence, what you might need to change, how to use particular scales to determine anxiety, depression, those sorts of things, and also learning and doing things together, really working in partnership and feeling that there is an opportunity to learn and do together.
It's important to recognise that any quality improvement cannot just rely on the technical skills. You do need the interpersonal skills and the ability to learn together. Otherwise, it simply doesn't work. But we won't talk about that today because that would take too long.
So when we've been working, when we've used communities of practice, we're absolutely aware that every individual that comes and the organisations that they are coming from and working with will have Mindlines. And so we need to allow key people to evaluate and meld the widest range of relevant evidence together to understand and take account of the full context in which they're working and the context in which they hope to change, and to ensure that all the key people, including people who aren't too keen on this research or knowledge exchange, are involved and learn from each other. One of the critical things I think about our work and about the work that you're promoting is about full engagement and facilitating relationships, which promote trust, encourage trust, maintain trust, but also bring about purposeful, agreed change. And so I've said already, we use communities of practice to do that. And for those of you who don't know, here's a slide that defines them. But basically, a group of people who share a concern, set of problems, a passion about something, and they get together, either informally or formally, to deepen that understanding and knowledge. So they're helpful in getting people together, obviously, to implement and reshape knowledge, to promote learning by developing and sharing collective Mindlines, and adjusting them as well, as problem-solving mechanisms, moving knowledge and innovation into practice, and really importantly, particularly I think when we're thinking about mental health, of giving members ownership of changes so that they can sustain those changes that are being made in practice, or that they're being asked to make about their lifestyle and the way they work. And I'm really sorry for the strange noise you're hearing in the background, but it is our dog who's decided she needs to escape from the room we're all in. Communities of practice are also unhelpful, of course, because they can be quite rigid, have rigid boundaries and block the spread of knowledge. And they can also perpetuate bad practice as well as good practice. So it's important that they themselves have mechanisms for appraising shared ideas and people's mind lines. And they also might, and we've seen this in many instances recently around the pandemic, perpetuate groupthink, and they themselves can become an echo chamber. So a little bit of a warning there, as well as encouragement for communities practice.
We talk a lot about what we call robust critical dialogue, which is very important. It's not just about being nice and kind to each other, it's also about being critical of things and understanding why that criticism may be appropriate. We're going to show you a video now which will explain our method. At the East of England ARC, we make great efforts to implement research into practice. The ARC's job is to do applied research that helps solve problems and improve services using sound, scientifically researched evidence. And the ideal researcher uses co-production methods, working with all the key people who might be expected to use the results in practice. Well, the research may have yielded useful findings, but now what? How will that make a difference in practice?
Meanwhile, the practitioner and their organisation have a problem rather like the one the researcher worked on. The ARC, through its close links with both parties, spots the opportunity to apply the research findings. The ARC's implementation team bring together the researcher and practitioner. They explain their ideas and talk through the possibilities. Then the implementation team consider whether the research findings and the organisation meet the ARC's criteria for an implementation project.
They think about the potential for implementation and who will need to be involved. If it looks promising, and with the senior executive's blessing, all the key relevant people are invited to form a community of practice. Service users, practitioners, managers, commissioners, whoever matters to making it work.
The facilitators ensure there are respectful, critical conversations to help people in the community of practice form relationships, often new ones, that enable them to share their in-depth, first-hand knowledge of the likely implications of the research. So they all learn about the good and the bad points of the research if applied in their context. They collectively explore the likely opportunities and barriers and who else needs to be involved to help the change happen, and they agree a plan.
As they set about the task for real, they inevitably have to tweak and reshape things, changing the planned implementation of the research to fit the context. They assess how it's going by using success criteria that they themselves have agreed. Usually they realize that they need to adapt things, both in the research findings and the context where the findings are being implemented.
The community of practice, who usually meet around 4 times, continue to check out and adjust things based on their agreed measures of success. This becomes a cycle of small tests of change. Our emphasis on personal and organisational relationships is crucial. The relationships help the key people become more committed to the project and to recognise that adjustments are needed on all sides. They know now that to keep making it work, they need to keep learning from each other, which is what being in a community of practice is all about.
They eventually agree that they've sustained the research-based change that was needed. The organisation's performance is improved. And the researchers and practitioners, and indeed all the community of practice members, have learned something and made tangible research-based improvements. Everyone's pleased, especially the people who use the service.
Every project is different, and everybody learns. The implementation team discovers something new each time and spreads these lessons across the ARC, growing implementation skills and capacity.
Practitioners and service organisations are encouraged to spread not only the research evidence as appropriate, but also the implementation principles they've learned about. And the researchers take the lessons back to their colleagues, so developing more collaborative applied research that can be put into practice.
Please get in touch.
That service is no longer available because we've now left that job. But one of the projects that we were involved in will interest you particularly, I think, having listened to your last panel discussion, because it was about trying to deal with the inappropriateness of institutional care. It was, to take Tanya Dodd's phrase that I noted down, the individual craves to be with the family and to move away from institutional care, which is so inappropriate. And this was working with people who have severe learning disabilities and challenging behavior, and using a method called positive behavioral support, PBS. This had been shown by both research evidence and experience in one part of the country, in Cambridge, where we live, to be successful. And we were trying to spread it to another part of the country nearby, which was still sending their young people to institutions, because the whole point of positive behavioral therapy is to integrate people, give them the choices they want, to live with their families in the community and deal with the problems that they really wish to deal with themselves, giving them hope, a life at home, and health, to echo your strapline for your conference. So PBS, we also showed, can save an awful lot of money. So the local authorities, our economists found, were saving £4.5 million sterling over the period of a year by not sending these people to implement that using the method that you've just seen in the I've got internet connection is unstable again. Can somebody tell me if you can still hear me?
We can still hear you, Dr. Gabby.
Ah, good. Right. You probably heard me swear under my breath then. Right. So, this is an example of the impact that one can have helping people. And the point was that we brought together a community of practice of people from all sorts of different parts of the organizations of the area, including patients and carers. Well, actually, in this case, not the clients themselves, but their carers, their families, each of whom had their own mindlines about what was appropriate as care for somebody with extremely challenging behavior, and the role of institutions and the role of family care. People from the education sector, from transport, from all sorts of places, to try to understand what would be the right way to implement this in the locality. And we're pleased to say that the local authority decided to adopt the positive behavioural support system and change the lives of these families. So this is just one of the sort of successes. So let's just summarize where we are with the principles, and Andree is going to take you through that. Wait a minute, I'll take that away. Right.
So I think it's good to wrap up now. So the principles from our work are that research uptake is not linear, and it's not a rational process either. Research findings are melded. They bring together different sorts of knowledge in Mindlines, and they're shaped by multiple contextual pressures and tensions. Knowledge is transferred and research is transformed into knowledge in practice in context, and these things satisfy many demands and constraints. Each actor transforms the knowledge. And John talked about cardiologists and the system, but equally you could look at various professionals in mental health care and do the same thing. Many things are transformed from how they first start out. Every actor has a different understanding, and that understanding will change the outcome. And Mindlines, both individual and collective, embody that entire process. Implementation, I think you've gathered, is fundamentally a relational activity as well. And the four circles model is very important when we think about how we can implement evidence, particularly using, for us, communities of practice, and making sure that also in those communities of practice, implementing knowledge is about using the right skills too.
Which are not just technical, but organizational and interpersonal and learning skills.
So those essential skills, when we're thinking about implementation, are all listed here. You can see implementation in red on the left-hand side, and you can see exactly what the skills are that are critical really to successful implementation. And I might say to successful drawing out and manipulation of Mindlines to ensure that you do have knowledge in practice in context that is relevant for your needs, your clients' needs, and your community's needs.
If you want to know more about Mindlines, we brought out a book last year in which people have used the Mindlines model in many different contexts and put it into practice. And just a quick plug for our book, but don't feel in any way obliged. Simpler just to look at the two-page editorial that I pointed out earlier. Before we leave you, we just want to quickly show you another resource that you can look at online. This is only 1 minute. But the resource is something you might... Hello, and welcome to our Art East of England Implementation Art Gallery. I'm John Gabby, and this is Andree. Whose idea this whole thing was.
Hello, we're here to briefly explain what the gallery is about, why you might find it useful, and how to make the best use of it. We've been helping people to implement research for a number of years now.
Well, decades, in fact. And we thought it'd be nice to pass on some of the principles that we found useful. To make that a bit more fun, Andree suggested we put it all into this online gallery. Although you can, if it's easier for you, just see the same stuff on the Art East of England website.
The exhibits are all based on the implementation methods that we've developed and used over the years. They're a mixture of well-evidenced methods, some of them based on our own research into how people use their knowledge in practice, things like communities of practice and Mindlines that you'll come across as you go round.
And there's a large slice of the art and craft that you need to be able to implement research out there in the real messy world of health and social care.
There are 6 main rooms in the gallery, and those of you who are just curious to get a general idea about what it's all about might only want to look at the first room. Then, and only if you really want to, you could just scoot around the rest of the gallery to check out the main exhibits and leave it at that.
For those of you who want to know more, perhaps because you're involved in an implementation project in your own organisation or you're just thinking about joining one, you'll probably want to look around all the rooms. And whenever something piques your interest, just try clicking on the exhibits. You'll find some theory, some examples of practice, and some helpful tips, which, by the way, are all in the top tips display room that you'll find in the centre of the gallery.
And most of the rooms end with a serialised story of an implementation project. It didn't all come out of John's head. It's based on our real life experiences, and it should help you put it all into context.
For those of you who are wanting to try an implementation project yourself or to help others to do so, you can go a lot deeper by clicking on the exhibits, watching the videos, exploring the top tips display room, and so on. And you can also make use of our workbook, which helps you to think through what you've seen and apply it to your own implementation project.
So please, go ahead and wander around and get as deeply involved as you like. If you get really into it, have a rummage around the storeroom, where you'll find around a dozen lectures from world-renowned implementation experts who've taught on our Art East of England Implementation Fellowship. They'll take you into all sorts of exciting theoretical and practical approaches to implementation.
Hours and hours of endless fun.
But if it's only a simple introduction you want, you can pop into room 1, check out the videos, look at the poster, and just, well,
enjoy yourself. And don't forget to use the suggestions box if anything occurs to you as you go around. We want this to be a living, growing gallery.
Start with a quick look at the gallery guides in the lobby here, and then go in, wander around, and have fun.
If you want to go to this, and it is free, by the way, free access, here's the link that you'll have when you get the slides. That's all we have Mindlines in mental health and in implementation, and we hope you find it useful. I'd like to thank all our collaborators over the years, and here are some of the follow-up references if you're interested. We'll stop that now, stop sharing.
And hopefully we're back with you. We had another little bit of internet connection problem then, but I think we're here. And we might have some time for a question or two. Please let us know if we do.
Thank you, Dr. Gabby and May. That was most excellent. We were able to hear you for the most part, and we really appreciate both of you explaining what a complex concept Mindlines is, but how it can be, in a way, very relevant to implementation in terms of implementation of knowledge and practice in taking evidence and doing that. We are actually out of time because we have this room for only a little bit. But what we can do is offer your email that you showed on your last slide to folks if they want to get in touch with you for questions. And we look to hosting you in person in Chennai at some point in the future because I know you weren't able to come. Yes.
We'd enjoy that very much.
Absolutely.
Thank you very much for your time, all of you. And I hope we haven't run over too much. Good night, I think.
Yes,
Thank you.
Have a good evening.
Thank you. Very close to night here. Thank you. So that brings us to the close of our day one of the conference. We've talked a lot about a lot of things, and thank all of you for your participation. I think in the realm of homelessness and mental health, we've touched upon programs and services and aftercare and acute care and a little bit of long-term care, talked about policies and budgets. We've talked about lived experiences, the importance of hearing those with lived experiences, the importance of research, the importance of training and education. And I think we're going to come back with all the vigor tomorrow to really discuss long-term care approaches in the community, because that is the theme of the day. But before we end the session, we'd like to thank our sign language interpreters, Rose, Nitya, and Silas, for doing a fabulous job today for us. Our very young note takers and rapporteurs who've been taking notes for our session, and our lovely photographers. So thank you everyone for being here, and we'll see you bright and early tomorrow. Thank you. And please use this time post-conference to talk to each other, meet and mingle, have those discussions and network if folks aren't too tired. But we'll see you tomorrow. Thank you.